Dr. Skip, say
Morning,
hi to
everybody.
Dan.
Hey,
Oh,
Dan,
I like-
how are you?
Good. How are you? Good to meet you.
Oh, I like the haircut. That's you. I noticed these things,
Just
Skip.
getting ready.
You look sharp, man. You ready for business?
Oh, yeah, thanks. I forgot we weren't just straight audio.
Oh, well,
Got an
sort of we
ultimatum.
are.
Got an ultimatum, Pete. I had to cut the top or the bottom, and so I cut the top.
Oh, yeah.
I was
What?
told I looked unhoused.
I'll say a good choice.
Yeah, right, Jay?
Unhoused.
Yeah, I'm in good company. Yeah.
So, hey, Laura.
Dr. Laura, say hi to Dan.
Hello,
Dr.
Mr.
Dan.
Hello.
And it's Laura and Dan. We're
Hi,
going to keep
Laura.
the doctors out of it.
Got it. I'm gonna
Nice to meet you.
let's get my shade down here so you can blind everybody.
Sure.
Oh, yeah. So
Yeah.
guys, if you congratulations, if you look on Google for Neurofeedback Podcast, we're at the top. So somebody did something. So congratulations. It's these wonderful guests that we have on, like Dan, to help continue the process. And Dan came on, man. We were worried he was under the weather, but he said, you know what? I'm going to hydrate, and bam, here he is.
Here I am.
He already did the intro, one take. So now
Wow.
it's up to us, and who knows where the tangents will take us.
I was contacted about a week ago by a Google researcher who is interested in applying Google's AI and machine learning stuff to EEG. So, we may have had a little boost from inside. Who knows? They may be searching for us from inside as well. So,
All right, we'll take the algorithm. We'll take it.
so
Hey,
yeah.
Jay, how'd the remembrance go last week?
Well,
Rough, I know.
it was a wonderful experience to have to go through for an awful reason. Having lost a whole bunch of very key people. It's like the bottom being torn out of a pyramid. It's almost impossible to imagine how the field stands when the foundation's been pulled away. Foundational people for heart rate variability, for EMG, for EEG, for teaching. A major manufacturer, and then some unexpected young, Joe Castellano was 49, and that was not expected. Joe Camilla was mid-90s. He had his birthday, I think, yesterday, if he would have still been here. So,
Yeah.
But what was wonderful about it is it was, a Zoom meeting, and you could look on screen and see people that you've known people that I've known for 48 years. Some very old time folks, and all the way through to folks I've met that are younger, and some students who popped in. It was like a family gathering, and that was the wonderful part about it. Now, it took me a day and a half to dry out my eye patch. So, it was a tearjerker as well, but, it isn't every day you get to see Barry Sturman essentially face to face, and have a nice chat with him. He said he was in the fourth quarter of his life. And I said, well, Barry, there's always overtime, so, and he laughed, and I said, well, it's sudden death overtime, so, but, we had a chance as a family to mourn the losses, and it was full of laughter as well as tears. And it was a good event, and it was open to anybody and everybody, regardless of affiliation within the field. So there were folks that weren't necessarily AAPB aficionados that popped in, well, for to say goodbye to all these key people.
Right.
So
Well, here we are, Jay. You're a tough son of a gun, man. We'll take another show with you, man.
I've been warning them for a decade or more, actually, that my time is up. I don't know when it's going to happen, but I'm way past their estimate now. They gave me a half a chance of 10 years, 28 years ago. So
we're all on a one-day contract, right?
Yeah.
If that. Okay, guys, let's get this this caboose going. Welcome to NeuroNoodle's Neurofeedback and Neuropsychology podcast, featuring our neuropsychologist, Dr. Laura Janssens, Dr. Skip Wren, and neurofeedback legend Jay Gunkelman. Our goal is to promote options for better mental health. Specifically, we focus on the objective data you receive from a brain map and the positive results of training with neurofeedback. This is an all-star cast that are more than happy to share their knowledge with you. Please give us 5 stars on Apple Podcasts, subscribe to our YouTube channel, be a Patreon supporter of our show, get early content, behind-the-scenes action, as well as partake in our members-only NeuroNoodle Network meeting. If they can't hear us, we can't help them. If you're not a subscriber, visit neuronoodle.com to sign up for our newsletter. My name is Pete, and today we have on the show Dan Long. Dr. Dan Long. That's the only time I'll say the doctor, Dan. He has MindFit Clinic. He's a director, testing and service coordinator. Dan, thanks for coming on the show today.
Yeah, thanks for having me. It's good to meet you all. Nice to be here.
Now help me get this all right. You're out in West Virginia, right? Tell me about MindFit, the clinic, what you guys do out there in your background.
Sure. MindFit started in 2009. Essentially, the program is the mission of our program is to help students overcome obstacles to achievement. Essentially, we offer a range of services to do that. We offer academic enhancement services, cognitive enhancement services, and we do some assessment as well. The cognitive enhancement services is how we got our start. I could share a little more on that in a moment. And so we do, things like cognitive training and neurofeedback for students of West Virginia University who are struggling with attention or other cognitive issues. Pretty early on, we also started getting approached by high performance athletes. It started when we had a WVU Rifle team is a pretty big deal here in our state. And we had a rifle team member approach us some years ago and say, hey, listen, there was this guy last year from India who won the gold, and he was doing neurofeedback. I hear you do neurofeedback. What do you got? And so we worked with WVU Rifle through 4 consecutive NCAA championships, Olympic medals, and then even had the chance to serve as a consultant to Nike. So it's not our bread and butter, but it's something that we do. The academic unit, you could kind of think of it in terms of sort of like tutoring in a way, but it's a little more enhanced. The approach that we use is one geared toward helping students become more autonomous learners, helping to build their capacity through learning new skills, broadening their metacognitive skills, if you will. A lot of that's informed by some cognitive science. And then we do some psychoed testing as well, psychoeducational testing. We started back in 2009. Originally, we started because our psychiatric colleagues were getting flooded with students requesting stimulant medication evaluations. And they were savvy enough to realize that self-report alone was probably not a good way to make those decisions. And at the time, I was a senior staff psychologist with the counseling center, as well as the coordinator of testing services on campus. So we ambitiously crafted a screening protocol that did a few things. It provided some quantitative data to help inform those psychiatrists' decision-making. It also gave us the chance to start meeting with students to help better their understanding and change their awareness of what ADHD is, as well as the myriad other factors that could be affecting their performance other than purely cognitive ones, things like, sleep, substance use, that kind of stuff. And we even published a study a few years ago. We developed like a multi-tiered validity approach to understanding whether students who are presenting to our clinic are earnest in their presentation, whether they're putting optimal effort forward in the testing that they undergo. We published something in Adult Applied Neuropsychology a few years ago on that. So we're meeting with these students, doing testing, and then realizing that we didn't really have much in the way of referrals. You know, it was, I guess, go see a psychiatrist, maybe work with a therapist here on behavioral management kind of stuff. And that didn't sit well with me. I tend to be a person who believes that we already have within ourselves a lot of the resources we need to improve and enhance how we're doing. So that's when I started my journey into neurofeedback and cognitive training. And I would say cognitive training is a bit more my area of expertise. We developed our own cognitive training method here. Some 2019 data with the approach that we have is shown to be pretty effective. About 10 weeks, the cohort that we had, was a small N, about 46 or so, but they only received cognitive training. Their attention composites on the CPT improved by about 2 standard deviations on average. 70% of them no longer look quantitatively impaired at the end of that 10-week period. The other ones are trending. Struggled to find a neurofeedback intervention that was working well with their population. Tried a variety of things, got consultation from some of the best, but it's a very interesting group or population that we work with. Again, many of whom are presenting ostensibly with attention issues, but also have a history of traumatic brain injury, cognitive disorders, and the like. And they want to see results right away. They don't necessarily have the patience to be told 20, 30, 40 sessions, you might see a change. Our cognitive training protocol was producing changes fairly rapidly, very tangibly for them, so that was exciting to them. And then with neurofeedback, some of the interventions we were using were producing these miraculous kinds of outcomes, but not consistently for all. And so it wasn't until recent years that we started using a few approaches, including ISF, that was really helpful for our population. And now where we are today is we're starting to combine approaches for the first time. We're doing task-based neurofeedback, which is neurofeedback that's administered under task-positive conditions meant to enhance both phasic and tonic aspects of attentional functioning. So it's neurofeedback under cognitive load, and that has been my passion now for the past couple of years.
Can I ask a question on behalf of our parents?
Sure.
I don't have any of the degrees. Okay, I'm the layman of the group. I'm going to ask the questions that the parents would ask, and then Dr. Laura, Dr. Skip, and Jay can ask the clinician and technician questions. If a kid in college is going to study, they're going to try to get Adderall or some type of drug to give them an edge to pay attention. I haven't been into college in a long time, and it's a coincidence on our own NeuroNoodle site. I have an ad going out with a bunch of pills of Adderall and saying, hey, instead of taking these, come through. How does it work at the school? The kids come in, they got to get tested to see if they can get a prescription. What's the process? And then if the docs want to pitch in later to show what they can find on the QEEG and what the neurofeedback protocol is, I'll hang up and listen for my answer. Thank you.
As far as what evaluations required, that varies markedly. We're talking university and counseling centers and the like, or psychiatric services. So at some institutions, you might go in just like you would to a medical provider, and based on self-report, that physician's going to prescribe you, stimulant salts or whatever. In other places, their standard perhaps is a little different. They may have some hoops you have to jump through, an assessment protocol you have to undergo, and that ranges. Some require really comprehensive psychoeducational testing, 6 hours plus of testing, hopefully broken up across multiple days, but a lot of times I've seen it in one day, which is awful. It's a bad way to get an accurate depiction of a person's skills and abilities. And then, they'll take that data and they may, consult with their psychiatrist on staff, and there'll be some discussion about that. In other places, they may have a screening protocol, some nothing at all. So I think it really varies from. Interestingly, I've been getting more questions. I'm a part of a national listserv of college counseling center folks who administer psychoed testing. And in that listserv, there's been discussion over the past year plus about, hey, is there something that we can do in the way of a screening that's not quite a very comprehensive psychoed battery, but still gives us some objective data to help inform decision making. There are strengths and weaknesses of just about every approach, right? But I think some data is probably better than no data.
Dr. Laura,
Dan,
Dr. Skip. Yeah.
Thanks, Pete. Dan, I had a couple questions, and one is about something you mentioned. I wonder if you could just highlight it again so folks might be able to access it, maybe even Pete can throw it in the notes for us. You mentioned a validity approach, multi-tiered, that was published. I know lower 48 for sure. Up here, it's not as much emphasis, meaning validity for tests, not that we don't care up here. It just seems a bigger focus down in lower 48 to ensure that folks are presenting authentically, and I'll just say it that way. So is there, can you just repeat your validity paper?
Yeah, sure. So, well, the first thing, let me preface this by saying, the first thing I teach our doctoral students when they train with us, I quiz them, what's the first thing that a malingering test cannot tell you? It cannot tell you if a person's malingering. That's the trick. So I appreciate the verbiage you use there, which is, are they putting forth optimal effort? And we're hoping to get a glimpse of that. And there's no single test that does that, just like everything in science. You hope it's subjected to a multi-trait, multi-method kind of approach. So the study that we published on was using a performance validity measure. The one that we use in the publication is something called the NV-MSVT. It's the non-verbal medical symptom validity test. It's okay. Paul Green, who's a neuropsychologist in Canada, designed it. He has tried to do his best to make it pretty bulletproof. There's some really compelling data. So it's a test that is ostensibly a memory test that really requires very little memory. It's actually an effort test. And essentially, folks with the most severe forms of memory impairment, fetal alcohol syndrome, folks who have intellectual disabilities, folks with dementia, they all pass this thing with flying colors. The only area that they struggle in is this one particular condition, which is not surprisingly the free recall condition, but they still, generally speaking, are able to pass this thing. So if you are a healthy young man or young woman in ages 18, 19, 20, and you're coming in and you're failing this thing, but you're not walking into walls, we have reason to be concerned about what it is you were doing during that administration. Now, that's so what we did is we administered that, and we also administered a pretty popular CPT, continuous performance test, computerized measure of attention and response control. We used the IVA. And so we gave this group of individuals the IVA to look at their attention, and then we gave them this NV-MSVT, and we saw who passed the performance validity test and who failed. And then we asked the question, how do their scores on the CPT differ? And could we derive some empirical cutoffs for whether you appear to be someone who may have an attentional impairment and is trying well? What would be very rare and unusual is you're kind of coming up with no impairment, but you're failing the performance validity test. It's very unusual and a very, very tiny percentage. And then every other permutation in between, right? And so we were able to generate some kind of cutoff numbers on the IVA. If you score below this combination of numbers, it may be that you fall into this group of people who aren't putting forth optimal effort. Now, in our clinic, we combine this with a variety of other things. Again, we wouldn't lean on just one test alone to help us determine that, but we also have clinical interview and some other things that we're doing during the time that we have with someone. And a lot of times it can be fairly obvious if a person's not putting forth optimal effort. They present, they say they have ADHD, which just started yesterday. It's only appearing in one setting in school, never affects them anywhere outside of school. That's suspicious, right? And they sort of tell you maybe they have a substance use history. They might, tell you that they're partying on the weekends, who knows? And then you got to offer them a variety of options for ways to address it other than stimulant medications. And they bat them all down. The only option they want to consider is stimulant meds. Then their scores on the IBA are, beyond, they're actually lower than the mean score of those with ADHD. So it looks markedly lower than a genuine impaired population. And they're failing this NVMSVT, a symptom validity test on top of it. And you take that whole picture together and you start to think, I think we're going to recommend that you do a few things before we pass you along to psychiatry, right?
Okay, great. And if I had just a comment on that, and then I don't want to steer us in a whole different direction. I see Laura wants to ask something too, but I guess I have a not so hidden agenda in that I've always had a beef with this idea that we are, and I'm not implying this by you guys at all, Dan. I'm actually trying to just, kind of flesh this out, but that we're cops, or we're human lie detectors, and we're trying to, determine whether someone's being truthful or not. And it's always kind of rubbed me the wrong way as what we're supposed to be doing as we connect with other humans in a therapeutic environment or whatever it might be. But so the MMPI, I think, has something that's literally called the lie scale, or it used to, in one of its versions.
Yeah, the L scale,
so
right?
It's like, man, I'm all for, of course, gaining someone's authentic or true performance, or trying to determine effort levels. It just seems that would then offer us an inroads into, hey, what's up with effort? And are you just wanting some stimulants? Okay, good, we can figure that out. But what's going on that you're having difficulty in this environment or in this context, putting forth your true potential or whatever it might be.
Mm-hmm.
So anyway, within that is, again, now it's not hidden at all, my agenda, and maybe it's a different conversation, different time, but this seemingly, kind of headstrong approach in our field, neuropsych in particular, of, catching people doing something inauthentic. It just doesn't feel like the right approach. And we're in the same camp, it sounds like.
Yeah, I don't particularly, I don't personally approach it that way. I think our psychiatric colleagues are very interested in getting some of that data, because they're very much aware that about 35% of the population that presents for stimulant drugs really don't have attentional impairment, and they're wishing to use it to party, restrain their weight. There's a variety of things for which to use it, and it's a controlled substance. It used to have a black box warning, potentially dangerous, and then the empirical efficacy of using stimulant medications is mixed. So I can appreciate their concerns. I use it as an opportunity to talk with a person, and I like how you started there. If we use this as a microcosm, this time that we have together, and we have a sense that a person's not putting forth optimal effort, is that something they characteristically do? Could we derive an accurate depiction of their true skills and abilities if they're not doing that? Have they considered other options? Why not? If there are other options, why wouldn't they consider them? So I really like being able to tell people and help them learn a little bit about what stimulant meds can and cannot do. Doesn't give you superpowers. Might improve your reaction time on a CPT measure. Doesn't make you more careful. Doesn't necessarily change your error of commission rate, right? So yeah.
And have you heard of neurofeedback, by the way?
And have you heard of neurofeedback? That's right. Yep.
Laura, I think you might have something.
Yeah, I was just going to jump in. He already kind of addressed it. I was just going to back it up a little bit, that, what we're talking about is, folks who come for an assessment for ADHD, and he quoted my statistic I was going to throw out there also, is that, about a third of the people who go in for medications for ADHD are, quote, malingering, which means they're faking so that they can get the medication. The research also shows that not only is it, college age students who are trying to get their meds, but the same statistics apply to even younger kids 8, 9, 10 years old who go in for a psychiatric evaluation for medications are also prone to malingering, maybe not in an intentional way, but that there's some influence by parents and peers and schools and kids at even young ages know the consequences of, quote, failing the neuropsych evals. And what's interesting, I do a lot of, especially lately for some reason, I'm having a trend of court referrals for disability. And the questions are these folks malingering their illness so they continue to receive disability? And it's pretty cut and dry. If you don't put effort testing or symptom validity testing in the neuropsych evals, they throw them in the garbage. So yeah, it's happened. I mean, I've had this discussion with a couple of attorneys this week that was the first question they asked me: do you do symptom testing or symptom validity testing? I said yes. We're required to, being board certified in neuropsychology, to do that for that reason, that if it goes in front of a judge, it has to have those tests in there. But the point is, on one hand, can they be malingering because they want the secondary gain, possibly? But then there's this other question of what is effort? What are we testing? Even with neuropsych testing, there are no real tests for effort. I mean, as far as if you legitimately have no motivation, you can't get up, can't get started, can't get moving, there are no neuropsych tests for that. All of that kind of testing is more anecdotal, just kind of listening to the story. Yeah, I have trouble waking up, I have trouble getting going. And to Dr. Long's point that it's in all situations. It's not just when I have a math test, I can't get up in the morning, but if I have to go play tennis, I can't get up in the morning either. So it's, all around an interesting topic. You can't, I think he was getting to the point, you can't fake commissions on a continuous performance test. That we call that pathognomonic of impulsivity. If you have one error, if you have one slip, you kill one squirrel while you're driving, one incident of that is a problem and pathognomonic of an impulsivity issue. So it's hard to fake a continuous performance test. But back to our show here, it's hard to fake a QEEG. You're going to show those frontal areas having disinhibition, dysregulation with the scan. So, we can do, me and Skip do 6 hours of testing, kind of come up with the same result in 5 minutes. Yeah, there's underperformance of the frontal lobe or hyperactivity in different areas. And the QEEG is a good supplement when we do our testing, for sure.
Interestingly, we do see about 20% of the ADD-ADHD population have unexpected epileptiform discharges in the EEG. And for those individuals, a stimulant medication may be the first time they ever actually have a seizure. So, the stimulant medications aren't always safe. I remember back in the 60s and 70s when amphetamines were discussed as amphetamine psychosis, and now they're handed out for ADD to kids like candy almost. Now, I like to see the EEG because we can match the medication well. If you have frontocentral theta, methylphenidate, Ritalin, or one of its longer acting forms like Concerta, is a perfectly good match. It's a dopamine deficit in the striatum, and it's a dopamine reuptake inhibitor. It's a perfect match. If your alpha is very slow, an amphetamine is a norepinephrine agonist, and it speeds up your alpha. So there's a good match there. If your frontal alpha is in excess and it's not slow, it's normal, you'll probably respond better to an antidepressant than a stimulant. If you have beta spindles in the EEG, you're going to react not so well to any of the stimulant medications, and you're primarily in need of a channel blocker like guanfacine in tune of 10x. So the EEG, QEEG can help pick the medication that's a good match for the person. Additionally, when we do a CPT task, like an IVA or a TOVA, if you have the EEG hooked up already, you can actually do something called an event-related potential. The event-related potential can be broken down with component analysis into its parts. You can literally see whether the person visually detects the signals properly, whether they're processing the signal visual properly through the brain, detecting what it is and where it is they're seeing things. That you can see the motor engagement. If that's component is not working, you have omission errors. You can see the motor inhibition, if they'll have commission errors, if that's missing. And you can have a perfect visual CPT performance and have OCD and have the anterior cingulate late latency potential at about 400 milliseconds going off repeatedly, telling you made an error when you didn't make any error. It's just common for OCD people to have these error messages, which is why they go rewash their hands or recheck the lock or whatever. So you can literally see the processing of the signal that they've just looked at through the brain, identifying which piece of processing is in error. There are people that just have executive control of motor engagement or motor inhibition. Those are pure ADD. Some have sensory processing problems as well. You see that in the sensory components. And then there's always the OCD, ODD comorbidity where you actually see the cingulate problem, late latency potential. So I like to see the EEG, QEEG, but I do like to see the visual CPT added in with the EEG recorded so we can actually look at the decomposition of the P300, which is a cognitive event-related potential. So with those testing, we can usually tell you what system in the brain is not working, what likely the symptom is, and what medication or intervention can be used to fix it. Neurofeedback or neuromodulation interventions, medication interventions, there's lots of ways to approach changing brain function. And if you have a good measurement of what the brain is doing, it allows you to match it really well with the intervention.
Mom and dad question here. My kid wants to take a pill. Can I send him to Dan's office and do a QEEG and figure out in 20 minutes, do they need this pill or not? Because people are lazy. They don't want to work out. They don't want to train. Okay. But can we just do the QEEG or the brain scan to figure out if the kid needs the pill or not? Just curious. And then follow up, I learned from Dr. Skip in dealing with psychologists, follow-up question is, Dan, you're at the university, and with the Olympics going on, and Simone and Naomi bringing mental health to the forefront, are you seeing any of the athletes? I know it's in summer season, but do you think you'll see a spike in the athletes at the school wanting to come in to get brain scans? The lacrosse players, the football players, to get a baseline before the season starts? I'll hang up and listen for my answer.
I have no idea on that latter.
Muted.
Yeah, there we go.
Sorry. I have no idea about that, how to answer that latter question. You're right. We're in summer period. We're just about to start the fall semester. So I have no way of knowing or predicting the extent to which those events will have some impact or bearing on what we see here. Sorry, I can't answer that one. As far as your first question, it's like, to me, that's like a trick question. It's my choice as a provider to no longer work with students who wish to be supported with stimulant medication. They have other avenues for that. If they have decided, despite my attempt perhaps to heighten their awareness to the research on these things or give them other options, they're hell-bent on going for stimulant medication, then they'll do so. And that's outside my scope of practice. The people that I work with are people who are either not interested in taking medication or are interested in a day where they're not taking medication. That's sort of where we want to get to. I find that it becomes very challenging to attempt to out-train their medication. And the effects of doing both simultaneously usually results in some very sticky situations. So that's my preference.
Hey, medications are for the older populations. We also give them to, younger kids, but I'm working on eval right now where the person is 4 years old and the parents are interested in, just kind of this black or white answer. Is this ADHD or not ADHD? And clearly there's all sorts of developmental issues that they actually would make lots of progress in occupational therapy or lots of progress in language therapy. And, the parents are kind of, in this black or white, again, medications, not medications. And again, there are other things. I mean, there's certainly neurofeedback, but at a young age, you can also have neurofeedback, but there's all these other therapies. And so, what we're talking about, I think just as a whole is, are people willing to kind of think outside the box and do things where they can own their training, own their treatment, own their symptoms, and make improvements. I brought this up before, and I don't want to hog everything here, but I got a puppy. He's now 8 months old. But what I mentioned when I first got him, I've had dogs, but never had a puppy. I YouTubed, dog training videos, and I soaked all those up. But the interesting thing about training dogs is one of the first thing you train your puppy to do at whatever, 4 to 8, 8 weeks old, is to give you attention. The first command is look at me. You take the dog by under the chin and you put him in your face or with a treat and say, look at me. And then you train them to look at you. And I was stunned. I'm like, well, it works. Hey, you know what? Now he's 8 months old. I'll say, look at me. He looks at me and he does all these other things, the treats. But the point is that we are not training our parents to say, look at me. We're not training our parents to say, hey, you know what? If you do these various physical activities, go to occupational therapies and other kinds of things, that they will improve their attention. So, bottom line is there's millions of other things that can be done. And, it's a societal issue in terms of, are you going to own these symptoms? Are you going to take control and make your own progress and develop yourself physiologically? Or are you going to go, like Pete said, the easy way, and he used the word lazy, but easy way to, do the treatment. So.
If you don't mind me piggybacking on what you said there, I think if there are parents watching, then, and if there's anything I could impart to them, it would be this: ADHD as a diagnostic category is an incredibly heterogeneous taxonomic category. And the important thing to know is that the phenotypic expression, the symptom presentation of inattention, sort of to Dr. Laura's point, they have lots of a variety of different explanations other than it is a purely cognitive ADHD kind of thing. Usually we diagnose ADHD, I don't mean we, but I mean the field, often awards an ADHD diagnosis when there's an unknown etiology for the symptom presentation. And if we don't know, then we just say, well, this residual category seems to fit the syndrome quite well. We'll just call it ADHD. And ADHD itself probably has many different endophenotypes. Certainly that appears to be the case. So when people present and they say, I have ADHD, the first thing I think all of us here, of course, do this, but I would certainly want parents to know that it's important to evaluate all the other myriad considerations that may result in the appearance of an attention disorder first and foremost. One of the things I used to do with doctoral trainees was present a slide where it shows essentially the symptoms that are consistent with ADHD, and I'd say, okay, render your diagnosis, and invariably they would say ADHD, cognitive disorder, what have you, and then I'd pull up lead exposure, which I had at one point. I had lead exposure when I used to compete in handgunning. I was shooting at a poorly ventilated indoor range, and got to see what it was like to live with a cognitive disorder for the better part of a year. In our clinic, we end up digging in and finding that probably the vast majority of people who present with ADHD, we often end up awarding them a different diagnosis once we're done with our clinical interview, with all the testing, with everything else. Young man who came to us a few years ago at our college counseling center clinic. He says, I have ADHD. He'd been to a number of physicians before. He was convinced that he had ADHD. We did a basic clinical interview and found out, no, he sustained a head injury. He was dropped by a relative when he was a child. He sustained a 2 and 4 millimeter lesion in his left dorsolateral prefrontal cortex. Is that going to create the appearance of ADHD? Oh yeah, for sure. But that's not ADHD, right? So I think that's super important that folks realize, and that yes, there are a lot of options out there that may actually be well suited to the individual that don't involve medication.
Yep.
Dan, thanks, Pete. Dan, if I can just summarize what you and Laura both saying, our Laura and I's mentor, Len Koziel, used to eloquently put it, ADHD ain't one thing. And he's a neuroscientist parading as a neuropsychologist, so he was able to then follow that up with some pretty good explanation. But yeah, it's a bunch of things that create what we see, and so by default we use the labels at our ready, which is DSM. Hey Pete, potentially I'm gonna blow both our minds, and I'm gonna ask Dr. Dan one question and maybe leave it at that. I don't know if I can do it, but I'm gonna try. I know, right? Can you tell us, Dan, what you're doing with the task-based neurofeedback? I know we got some, providers out there that are doing, air quotes, more traditional neurofeedback with a lot of effectiveness, I'm guessing. But can you talk about the task-based? It seems to be something that I'm hearing a little more about.
Yeah, so task-based neurofeedback as an intervention is not created by us. It's been around for some time. We've always been very interested in finding ways to start conducting neurofeedback under cognitive load. I always found it amusing that, well, first of all, some practitioners attempt to address attention concerns with a one-size-fits-all, well, we'll just focus on FP1, as if that's the grand answer for things, without even understanding that attention is not a unitary construct, and it's actually a multitude of large-scale brain networks and other things going on simultaneously, different forms of attention. Usually folks aren't even aware of that. But we wanted to find a way to start putting it under cognitive load, because we'd see most neurofeedback being conducted while a person could be sitting in default mode network thinking about what they're going to cook later on for dinner. And their brain, it's sort of like akin to me gesticulating, moving my arm like this and saying, I guess I'm kind of doing an exercise, and then expecting that to confer some benefit to my barbell squat. Maybe, maybe not, right? And so we were always interested in doing it, but for years I thought, boy, this doesn't seem like it's going to work. Our early attempts, it always felt like we were asking the brain to do two different things simultaneously. It was not a seamless integrated experience. And so I kind of abandoned it. And then one day I was working on a protocol, and it just sort of came to me, well, what if we set up a feedback scenario that allows neurofeedback to be a bit more seamlessly integrated with cognitive training? We began experimenting with it a little bit. People that we've been using traditional neurofeedback, a lot of times what we would do is we'd start with one, depending on our intervention model. Let's suppose they had a real fundamental issue with, I don't know, chronic state of hyperarousal, whatever that may mean for the person, okay? And so maybe we're doing some neurofeedback for that, and we start to move the needle, kind of hit a plateau, or we address it, and now we can start working on cognitive things. We don't usually start addressing things like executive function and memory until the more fundamental issues have been addressed. It doesn't make sense to do that. So let's suppose we address the fundamental issues, and now it's time to focus a little bit more on the cognitive stuff. So now we're doing neurofeedback protocols for the cognitive stuff. We might hit a plateau a bit. We're not seeing a lot of quantitative change, and the client's not reporting a lot of significant progress. We might swap over to cognitive training, or vice versa. And that's sort of how we would do it. We'd kind of hit a wall with one, swap to the other. We've been doing this now since 2009, okay? We see a lot of people with ADHD. I would venture to guess more than most clinics in the country. And so when we started integrating it, we started finding that the effects we were getting with our cognitive training seemed to happen a little more readily, rapidly. And so now we're collecting data. Of course, we're always interested in not only what are the outcomes of the variety of dependent variables that we're studying, but also what are the far transfer promises, the far transfer effects to what we're doing and the like. And so that's kind of what we do. We use the standard protocol that we use often will involve S-Loretta neurofeedback, ISF, S-Loretta neurofeedback combined with our cognitive training kind of approach, if you will. The cognitive training approach itself is very much unlike, I think, what people are accustomed to thinking about when they hear cognitive training. I think a lot of times people immediately picture the commercially available brain training games like Lumosity, those sorts of things. It's this kind of one-size-fits-all computer-driven approach. And the research, of course, on using approaches like that is highly mixed. And when we look at the reasons for why, and you see the problems with the literature itself, you begin to understand quite quickly why they're not getting the results. A lot of times their operationalization of cognitive training is very narrow. They might select, one task that may train a facet of cognition and then use a dependent variable that's multifaceted like IQ. And that's very much like if I build my bicep strength, will it increase my squat? Not really, it's kind of apples and oranges. One's much, much larger than the other. And then they sometimes don't measure baseline. So they might give you like NBAC training as your cognitive training task, but it's possible that half the sample's really good at it already. You're training them to the ceiling, right? But the biggest issue is that if you talk with people who've done cognitive training and self-guided cognitive training, they'll hit a wall, they hit a plateau. And at that point, they usually sort of give up. Doesn't seem like there's a place to go. Ours is a clinician-guided approach, which means we often use a computer. We often use cognitive training software to facilitate it because it's more convenient. But we're not dependent on it. In fact, we're not dependent on any particular software. It's an informed clinician who knows a lot about the cognitive system that can watch someone engaging in a cognitive task, identify where the weak link is, perhaps it's causing that plateau, and then scaffold or accommodate the task itself in order to strengthen the weak link. It seems to be very effective. We've gotten very consistent results. Occasionally I hear from people who go, oh yeah, I know something like that in the field of speech, working with aphasic patients or something else. Well, we've not seen anything quite published like this. It's in the literature. I'm sure there's a lot of analogs. I'm sure that what we're doing has, Vygotsky at its core, right? Zone of proximal development kind of stuff comes to mind. I'm sure it's not unique in a way, but we're just trying to make a systematic way of approaching cognitive training that's a little more tailored to the individual's needs. So when someone says, I have poor attention, I don't know what that means. We have to dive into that. I have poor memory. If you're not paying attention, it's hard to remember things. What part of memory? Is it working memory? If it's working memory, what facet of working memory? We're talking updating, binding, or Baddeley's model of working memory. If it's within Baddeley's model, is it the articulatory loop? Is it the auditory slave system of working memory? Or is it a central executive attentional allocation problem, right? We try to get really granular and then modify the tasks to help feature and strengthen that weak link. And it's been a lot of fun. We've had a lot of success with it. It's been really fun trying to combine it with neurofeedback and sort of see what that brings to bear.
And MindFit is part of West Virginia University, right?
Yeah.
Did West Virginia start it, or did you start it? Like, how did the college help me with that relationship? Because that's pretty cool that a school is getting that involved.
Yeah, I started it in 2009. I came here in 2003 for my clinical internship to finish my Ph.D. and got hired on the next year as a staff psychologist for the counseling center and was the coordinator of testing services. So I did therapy and testing services and all that good stuff. And 2009 is when I started the clinic, trying to figure out what options can we give to these folks who are presenting with attention and cognitive issues. And I've learned a lot from, so many great people in the neurofeedback community who are so damn smart. I hope to learn from Jay at some point as well, a wealth of knowledge. So yes, we've been doing it here since 2009. WVU's been great. They took a chance on something that probably seemed outlandish and weird. But but it's gone really well for our students. We've been listed recently, I think, as like top 10 schools for students with ADHD or something like that. Yeah, it's really great that they support us to do it.
Is the school offering courses on neurofeedback?
No, they're not. One time I got asked by the sports psych doctoral program to do a survey course. This was a lot of fun. A survey course over the summer for the grad students on cognitive enhancement interventions. So of course, neurofeedback was a big part of it. And there was even a practical portion of this. And it was really cool. One day we were doing the practical and folks are, trying stuff out, doing things, learning how to put electrodes on each other, doing some basic, like really basic protocols so they can just sort of experience it. And I hear this one young woman over to my left say, my lip. And I was like, oh boy. And I turned, I said, what's going on with your lip? She said, well, I had this dental procedure and I had this paresthesia and it's covered a portion of my face. And right now in this moment, the numbness has just shrunk down to this tiny portion on my lip. The rest I can feel. And I was like, wow, that's pretty miraculous. So whatever skepticism I held about neurofeedback, I think was addressed pretty adequately by experiences like that and lots of others. It's pretty neat stuff.
Because we're doing this podcast to help get the word out so more people will use it, versus pop a pill. And we always say that if the schools would teach more of it or have the classes in there, it would help. Does anybody got any feedback? Maybe this is a topic for another podcast, but like, what are the top schools for neurofeedback that are out there? I think it's cool. West Virginia is doing MindFit with you, Dan, but it'd be interesting to see, I don't know if we could, the NeuroNoodle top 10 schools for learning neurofeedback. I wonder what they would be. Jay would rattle them off the top of his head right now.
I think it'd be a good thing to end up pulling together with a little bit of research. Obviously,
Okay.
If I skip one, I'd end up with difficulty. So, at one of the interesting, it's not really a false positive diagnosis of ADD-ADHD because the diagnosis is behaviorally based. If they're inattentive and hyperactive and impulsive, they got the ADD-ADHD, stamp on the forehead. But, there's a very nice study that says between 25% and 50% of the adolescents that have the ADD-ADHD diagnosis actually have a sleep disturbance.
Yep.
And it's an extremely common finding. Essentially, if your eyes are open, people assume you're awake, but you can be in stage 1 drowsiness with the eyes open. And, you ask the person over, are you awake? And they're going to say, yeah, I'm awake. But they're not really present in a fully conscious way. If you're measuring them with the bispectrum, which can be used to measure depth of anesthesia, they look like they're actually drowsy in stage 1 or stage 2 sleep. The measurement off the forehead of the EEG that anesthesiologists use to titrate medication. It looks like they're already halfway there. So, they're really not fully conscious. Now, the kinds of sleep problem can vary. You can have primary disorder vigilance, which is like narcolepsy without a cataplexy. Now, they just can't stay awake. You sit down in your desk at school and boom, they just fall asleep. Well, that actually needs to be addressed with a different medication than a stimulant. You don't want to jack up their arousal. You want to flip them to the awake state. Use modafinil as a medication instead of a classical stimulant. Dr. Gevirtz, Gevirtz's program is a good one. But you can have an apnea and not sleep well enough at night, and you're drowsy during the day. You can have restless leg syndrome at night or periodic leg movement. You can have a behavioral sleep disorder. I mean, there's lots of sleep disturbances that can end up being problematic for your attention during the day. And the last one on their list is basically, well, there's circadian rhythm as well, but the last one on their list is actually people that have epileptiform activity at night that disturbs their sleep. There are people that have ESES, a seizure disturbance during the night in their sleep, and they don't sleep well. They're busy having a seizure. So if you have one of those sleep disturbances, you're going to look like you have ADD, and it's a difficult differential diagnosis, except with the EEG. If you have eyes closed, 10 minutes of EEG, and they fall asleep into stage 2 sleep in the first 5 minutes, you've got a sleep disorder, somebody that has to be sent to a sleep lab for a full evaluation. So we do catch sleep issues as well. And that it's astounding how many people end up having it. Again, the estimates of a quarter to half of the ADD population actually have sleep disturbances.
I'd say that's true in our clinic. That 100%. We routinely not only inquire about it during clinical interview, but we give a couple of sleep inventories, including the Pittsburgh Sleep Questionnaire. And there are people for whom they're both impaired, cognitively speaking, and they have a sleep issue. But for many, the primary issue is really that of sleep. I'm lucky to have a colleague here, the director of psychiatry here at WVU, Dr. Brian Quigley. He is mostly interested in looking at sleep for this population. So the man makes more referrals for sleep studies than he does writing scripts, which is wonderful. It's great to have a colleague like that, right? Yeah. And you're right, it's an absolutely huge epidemic, I think, in that population, and often presents like ADHD. Yeah.
And if you go back historically, SMR training, sensory motor rhythm training, actually trains the same exact mechanism, same nuclear body, and everything as a sleep spindle. It's a stabilizing rhythm during the day. It's a stabilizing rhythm at night. And if you don't have a good sleep spindle, you're going to have sleep onset insomnia and wakefulness, because during stage 2, you have a vertex sharp wave. That's the brain's response to a stimulus. If you don't have a good sleep spindle, it'll wake you back up. So you're descending awake to stage 1, you hit stage 2, back to awake. So you don't fall asleep easily. And then once you fall asleep, you bounce back up to stage 2 on your way up to REM, and you pop back awake. So you have wakefulness. So the simple SMR training ends up being really useful for insomnia, because insomnia ends up having this difficulty with an insufficient stabilization with sleep spindles. And it is trainable. And with a normal person with kind of a little insomnia, the Europeans showed 10 neurofeedback sessions with SMR was sufficient. But they found with severe clinical cases, 10 sessions was not sufficient. At Alliance University, in Dr. Gewurtz's student, Diego Garcia Rodriguez, replicated the treatment group, not the control group, just the treatment group, and did 24 sessions instead of 10. And he used very severe insomniacs that were recruited for it. And he found good success with SMR training for severe insomnia. The 10 training sessions with just an insufficient dose of training is all. Anyway, I think sleep is a core issue. I think one of the side effects of some of the neurofeedback protocols is sleep stabilization. And it's a wonderful side effect, enhanced neurocognitive performance on semantic and declarative memory, another side effect of the sensory motor rhythm type training. You got to suffer with those side effects, So anyway,
slow oscillations are being really, really tied, obviously, to sleep and memory consolidation as well. So I'd love to see some research done on, training and neurofeedback with ISOs.
Yeah, the slow cortical potentials are critical for brain function. They reflect glial activity. And actually, the bispectral index that I mentioned earlier for the depth of consciousness measures consciousness as an interaction between infralow frequency content at 0.38 hertz and gamma at 38 hertz. And to the extent that they're interacting, you're conscious. To the extent that they decouple, you're unconscious. And it's essentially are the glia interacting with the neural networks. Neural networks, when they form, create gamma. Gamma is an emergent property of having created a network. When you have glial interactions with neural networks, consciousness is the emergent property.
The listeners got their money's worth this show, I'll say. Dan, what's the best way to get a hold of you? Is it mindfit.wvu.edu?
Yeah, if you're trying to get a hold of me because you're interested in services for yourself, your son, your daughter, if they're coming to West Virginia University, or you'd like to learn more about the creation of a clinic like MindFit at your university, because we'd love to see that proliferate and other universities begin to offer clinics like this, you can use that. You can also contact me if you want anything more privately outside of WVU. My email is dan.long2, the number 2, @gmail.com. I've been doing some small cohort training on task-based neurofeedback.
Well, Dan, thank you so much for coming on the show today.
Yeah, thank you for having me. It's been a real pleasure to meet all of you and get the opportunity to chat.
You recommend somebody half as good as a guest as you are?